Welcome to Atrium Health Navicent Knows Health. I'm Cindy Busby and I'm here today with Dr. Art McCain. He's board certified in interventional and diagnostic radiology, and today we're going to talk about treatments for leg vein issues. Dr. McCain, thanks so much for being with me.
Thank you.
Could you first tell the audience a little bit about anyone with leg vein issues? What kind of symptoms do they present with? How do they know that it's a vein issue in their lower legs, for example?
Well, the biggest thing is going to be an aching and a pain, discomfort, and it didn't necessarily during the day. One of the biggest things that's associated with it is having restless legs at night, waking you up at night. And if a patient has the restless legs, waking them up at night, and they have vein disease, and we treat the vein disease, then worldwide literature says it's a 95% chance those symptoms will go away. That's a big result for something that a lot of people suffer from.
So when we say restless legs, is that the sort of the creepy crawly sensation, the burning, or you want to move your legs?
They get aching and you can't get still, and you know, it wakes you up in the middle of the night.
And does that come from, so the exacerbation of that, so the making it worse, does it come from standing on your feet all day, or by the time you have peripheral vein disease or leg disease, is it always going to do that? It's going to wake you up no matter what?
It's a combination of the pathology where the valves, you have valves in the veins in your legs. So the valve will open up, let the blood through, close off, and keep it from falling back down into your leg. But in people with vein disease, the valve breaks. So when you're up, the blood's trying to get back up to your heart, but the valve's not holding it in place, so it continuously falls into your leg. And it's kind of a bad blood, so to speak. It's the vein blood. It doesn't have as much oxygen in it as the arterial blood, so your leg tissues are continually bathed all day long with poorly oxygenated blood, eventually making them ache, making them swell because the increased pressure makes the fluid leak out of your veins. So it's a whole combination of those valves breaking.
And when we say the valves breaking, what is the disease process that causes that? Is that physiologic, so weight or vein disease, or what makes them do that?
It's mostly, almost always genetic.
Okay.
I mean, you can be skinny, overweight, but the vein can give way, and that's primarily on a genetic basis. Rarely I'll have someone who, when they were a child, got hit with a baseball and it broke the valve, so that one leg has it, but most patients it's a congenital thing. You got it from your parents or maybe your grandparents.
So if you see a bulging vein, most likely that valve is broken and it's not allowing it to work properly, whether it's...
Exactly. The blood just can't get back up to the heart. But you mentioned the bulging veins, and that's one thing. A lot of people think you have to have these big ropey looking veins on your legs to have bad vein disease, but actually you treat it more based on the symptoms of what I was telling you. Pain increasing during the day, waking you up at night. Probably less than 10% of my patients have the ropey looking veins on their legs. It's really, you don't have to have that. You can have totally normal appearing legs and have severe vein disease.
And does that mean that those veins that are diseased are more internal, they're not subcutaneous, or they are subcutaneous, they're below your skin, you're not seeing those ropey veins?
Yes.
I see.
It's below the skin. But yeah, there's two sets of veins in your legs. The one deep in the muscle where blood clots form, that you hear people that get blood clots to their lungs, that's where those come from, but that's not what we're talking about. We're talking about a second set of veins that's under the skin, as you mentioned. That's the ones that cause these symptoms we're talking about.
So when a patient, say they recognize these symptoms, when they first come to you, what's the progression of treatment before you might do an intervention?
First of all, we will do an ultrasound to confirm that they have vein disease, because there's more than one thing that can cause leg pain. I mean, essentially you have the arteries, the nerves, and the veins that can cause pain in the legs. And we treat all three in our practice, so when we're examining a patient, in our mind we're sitting there, is this really veins, or is it artery, or could it be coming from the nerves? So we sit there and assess at our visit, where could this really be coming from? And if we think it's the veins, we'll get an ultrasound, and that isolates where it is. Then we try conservative therapy, which is wearing stockings for 3 months before we do anything further. The symptoms persist, which they usually do, because the stockings make you feel good, but it doesn't treat the disease. And so then if they desire, we'll go ahead and treat the veins.
Now, is this in some ways both disease management and cosmetic? In the fact that some people do have the ropey veins and it does end up addressing that, so is it a combination
It'll get rid of those two.
They have pain
So in
and then they do that?
In that respect, yes, it'd be cosmetic, but yeah, the biggest thing is to relieve these patients of the pain.
So tell me a little bit about the procedure and then also how it differs from how this was done traditionally, that you have some different ways that you do it today that are maybe less invasive or quicker return to work.
Yeah, two ways that we treat them. The biggest one, most of the veins could be symptomatic down in your calves, but we start up here. And so a patient said, you're starting up here, my pain's down here. But if you think of it as an inverted tree, take a tree, turn it upside down, this is the trunk of the tree up here. We got to get rid of the trunk of the tree first, then we'll work on the tree branches. But we take a catheter and at the knee under local anesthesia, with me talking to you as I am now. You may wish you were sedated so you didn't have to hear me, but
maybe we could do that right here.
But we put the catheter in, and the tip of the catheter is a radiofrequency device, as we have talked about in the past. And the radiofrequency heats up the inside of the vein, burns it, which will then make it sticky, so to speak, and the vein will stick together. Your body absorbs it and it goes away. Versus the old-timey vein stripping, which I'm old enough to where I've done that, where you're put to sleep in the operating room, you put a wire in that same vein, put a little button on it, put your foot on the operating table,
and
like
pull
that.
And remove the vein.
And remove the vein.
And remove the vein.
And that is truly medieval. To do vein stripping nowadays is not good.
Not the standard.
Not the standard.
Tell me a little bit about when you are using the radiofrequency, ablating or burning the vein. Does that decrease perfusion or the way that the blood gets to the leg? I know we've got too much perfusion, which is why the leg is the way it is, but what is that doing in terms of reducing your perfusion if the body absorbs that vein?
It actually improves it. It's a physiologic thing. Think of having water on the floor and you have two pipes and the water's trying to get to the ceiling. And so you get rid of one of those pipes, same amount of water's got to go from the floor to the ceiling. It's going to go faster and quicker through what's left.
I see.
So now, it really increases the efficiency of the blood return from your legs.
By reducing the flabby veins,
the bad blood going
veins.
down. Yes.
Now, do the veins that remain also have these valve problems, or is that something you detect with the ultrasound prior to what veins you're going to ablate?
At the time, the one we ablate is primarily up here.
Right.
And then the bigger veins down here that are left, we treat those with sclerotherapy. You've heard of spider veins before. It's kind of like that, but it's a bigger vein. We do it a little bit different technique. It does the same thing. Instead of burning the wall of the vein, it chemically irritates it, which makes it sticky, and it sticks together and your body absorbs it and it goes away. Again, keeping away from that vein stripping type of procedure. But you do that for these down here, and veins can come back. As I mentioned, it's genetic. And the way what I tell my patients, you've got tons and tons of veins in your legs. And so imagine one right now that's like a dirt path going through the woods. About 5 or 10 or 15 years down the road, that'll become a 10-lane expressway and need to be treated again. Because it's genetics, it's just the nature. I can palliate it, but I can't cure it.
So tell me a little bit about vein health. If what we are referring to is genetic, what can people do in light of, yes, if they have this genetically, they're going to be there. Is there anything else that they can do to protect their veins to stop the swelling and the pain before they get to having a procedure?
I definitely encourage my patients to wear their medical support stockings all the time, even after we've treated them. I wear them all the time, every day anyway. And I realize this is Macon, Georgia. It's hot outside in the summertime, so yeah, you can't wear them, every day, every minute. But when you're inside with long pants, put them on. It'll help prolong that time from 5 years to 10 years.
Is there anything about time on your feet or putting your feet up, or the way we used to address it when you just say, well, just put your feet up, it's not going to
Most
solve
of that's
what's
kind
happening.
of old wives' tale. Like, don't cross your legs, you'll get spider veins. That's
Right.
not true.
Right. So if a patient recognizes this in themselves, do they go through their primary care provider, who might be treating this today, or do they come to you directly? Is it a direct to your service referral?
They can do both. You know, they can go to their primary care doctor and have them assess them and send them to us, or we give free vein screenings. Anytime, if you think you're having problems with veins, you can call our office up and just come in, and we'll do a free vein screening and assess and see if we really think it's that, or as I mentioned, it could be other things. Could be the nerves causing the pain in the legs, could be the arteries causing the pain in the legs. So come to the screening and we can sit there and assess, well, you probably do need to continue. Let's get you on some stockings.
And so these are some of the materials. So as patients come into your office, you have different kinds of materials. They can get those at the vein screenings also, and this is something that's done in your office.
Yes.
Okay. All right. Well, thank you for telling us so much about the procedure. Appreciate it.
You're welcome.
Thank you. And thank you for joining us at Atrium Health Navicent Knows Health. If you'd like to know more about Dr. McCain and his practice treating veins, please visit us at atriumhealthnavicent.org.